Welcome to today's June Ask the Expert call. Now, without any further delay, I'd like to introduce today's host, David Molman with Align Technology. David, you now have the floor.
Good morning, everyone, and thank you for joining us on today's Ask the Expert webinar, Tackling Complex Cases with Invisalign, presented by Dr. Bart Iwasiuk. You will earn 2 CE hours for attending today's program, and you will receive important instructions on how to obtain your CE certificate at the conclusion of the presentation. Additionally, CE hours will automatically be added to your Invisalign DrSite account. Please allow 2 to 4 weeks for CE hours to appear on your account. Please note you're able to listen to today's program via the webcast, and throughout the webinar, you'll have the opportunity to ask text questions, which our presenter will answer at the conclusion of the presentation. I apologize in advance that we're not able to answer everyone's questions since our time is limited, but we will follow up after the program to answer any outstanding text questions. Today's program will be archived in its entirety on the Education tab of your Invisalign DrSite, where you may also access archived versions of all of our previous Ask the Expert programs anytime for CE hours. It's now my distinct pleasure to introduce our speaker today, Dr. Bart Iwasiuk. Dr. Iwasiuk is an Invisalign elite provider who enjoys tackling tough, multidisciplinary cases. His interest in this segment of orthodontics peaked while doing his general practice residency at the University of Washington in Seattle. He received his BS from the University of Toronto with a double major in math and physics. Dr. Iwasiuk received his dental training at the University of Toronto and his orthodontic certification from the Eastman Dental Center at the University of Rochester. He maintains a private practice in the Greater Toronto area and is a local advisor for Invisalign treatment and a member of several American, Canadian, and international professional dental and orthodontic organizations. So without further delay, I'm going to turn the program over to Dr. Bart Iwasiuk. Dr. Iwasiuk, you now have the floor.
Thank you, David, and thanks everyone for coming and joining me to chat about complex cases. I know it's a long weekend here in Canada for Canada Day and in the U.S. for July the 4th, so I really appreciate you tuning in anticipation of the long weekend. I hope this is really worth your while. I was asked to do this presentation a few months ago, and I really struggled sort of breaking down what it is that we can do for complex cases, because quite honestly, I hope this goes over really, really well, and we can turn this 1-hour seminar into an immersive 1-week meeting down in Costa Rica, where we can really dive much deeper into these cases. But I did want to go over sort of how I think about these cases, how I sort of break them down to resolve them and to utilize aligners to their full potential. I do have to give you a bit of a disclaimer. All these opinions are my own. It's not aligned. So let's dive in. So really, when we look at complex issues, the complexity is usually developed by having a number of connecting parts. So really, from that perspective, most orthodontic issues end up having a multiple components that comprise the overall complexity. And I think for me, this really allows me to take really complex problems and simplify them by really narrowing them down and breaking them down systematically into smaller and smaller and smaller components. Because the simpler ones usually have a very reliable solution, and it's much easier for me to manage these cases in little chunks rather than look at the overwhelming big problem. The other reason why I sort of try to do it that way is there is a tendency to focus on what we perceive to be the most complex part of any given malocclusion and miss other things in the process. So for example, if you're dealing with an impacted cuspid, it's really easy to focus just on that and neglect the fact that we have to deal with a deep overbite at the same time. So I do try to systematically break this down and look at the smaller components, and that way hopefully I don't miss anything and don't just get mesmerized by what I perceive to be the most complex part of the overall malocclusion. So I sort of try to break it down into these 5 components. So this is sort of how I think about whenever I come across a case that is a little bit different, it's atypical, and I really utilize ClinCheck to look at these components. It's the tooth size analysis, which is a wonderful component to have, especially for any pre-prosthetic type treatment. It's something that used to be very cumbersome to do with plaster and volar gauges, whereas now it's wonderful. It's all built into the ClinCheck. ClinCheck allows me to look at a number of different treatment options because a lot of these patients can benefit from a lot of different approaches. So I couldn't do that before, again, with brackets and wires and plaster, but with ClinCheck I can do that very readily. We'll talk about dividing and conquering. That basically means breaking down different components of the malocclusion so you're not overwhelmed and looking at the whole complexity of the case. You can sort of address the simpler issues one at a time. I do anticipate auxiliaries and try to utilize them if I need them. I don't consider myself an Invisalign odontist. I do consider myself an orthodontist. So if I see something that I can do simpler or more efficiently with auxiliaries versus aligners, or sometimes marry them together, and we'll talk about that, and get the best of both worlds, I have no qualms about doing that. And then we'll discuss a little bit of a concept that I would sort of name selective anchorage, and that is to really just allow different movements at different stages and not always try to do everything all at once. So we're going to go through 5 cases today and try to highlight some of these features in ClinCheck and how these can be utilized for your cases. So we'll start off with one that's the simplest, tooth size analysis. And this lady presented to my office because she just recently lost the upper left bicuspid. It was endodontically treated and eventually had a fracture, and the fracture was subosseous, so she lost the tooth. And as is very common in these heavily restored dentitions, the restoration that was there was already quite a bit smaller than the edentulous site. These MODs, they just get narrower and narrower and narrower. And now she requires an implant, but obviously there's not enough space to place an implant. So she was presented to my clinic to basically create space to allow us to do an implant. And I love utilizing aligners for distalization. It's an absolutely fantastic orthodontic tool. But more importantly, once you get into these pre-prosthetic cases where you have a 4-unit bridge on the upper incisors, I'm not even sure how I could tackle that with brackets and wires. I certainly don't want to be bonding brackets to porcelain. And even if I could, I already have an established arch form because of this bridge. So it's really challenging to try to do this with any sort of wires. Because aligners are customized to our patients, it makes this process very, very simple. Now, she also presented with severe crowding in the lower arch, and we decided that we're going to end up extracting a lower right first bicuspid in order to sort of deal with the malalignment of the lower dentition. Might as well take care of it at the same time. Her radiographs are fairly unremarkable, except for the fact that you can see that her upper left molars are tipped mesially, which will make it a little bit easier for us to open up that edentulous site. So here's our ClinCheck, okay? And we're going to focus on a couple of things here. Obviously we want to have some sequential distalization, and again, I think aligners just do an incredible job of that. It's my favorite distalizing appliance. You do always have to make sure that you have a precision cutout so that you can back it up with elastics. The aligner distalizes the teeth, but the elastic ensures that you have appropriate anchorage. And then utilizing the tooth size analysis that's in the Bolton table allows me to know exactly what the size of that upper left bicuspid should be. In the lower right-hand side, where we're going to do the extraction, when I have these favorable cuspids that are tipped, I never upright them and translate them. I always lead with the root and do the uprighting at the very end. The standard default tends to be for them to tip upwards right away, but I find that it's difficult to control them that way. I also look at my tooth movement assessment to anticipate what's going to be difficult to do. And here you'll notice that it's the lower right lateral that will require a little bit of finessing at the end because it has quite a lot of root movement. So the ClinCheck is fairly straightforward. The only thing I got to make sure here is that I utilize some elastics to obtain the distalization and I'm leading with the root and only uprighting my tipped teeth at the very end rather than uprighting them initially and then translating. So we'll look at her progress. This is pretty much the end of her upper aligners. I ended up just having her wear elastics and get distalization. So it's quite remarkable that we can distalize 3 molars and do this very predictably. For me, the most wonderful thing is that if the aligner fits, I know exactly how large that space is. I don't even measure them anymore. I usually tell the technician, just make the space on the upper left the same size as the tooth on the upper right. I don't have to do the molar gauges. If the aligner fits, I know what size it is, and it's a wonderful way to communicate with the general dentist or the surgeon who's going to be taking over. And I don't have to put up with the cumbersome space opening and space closure that we do with brackets and wires, where we tend to do an open coil, we get too much space, then we do power chain, we get too little space, and go back and forth, back and forth. It's basically, if the aligner fits, it's exactly what we need it to be. You can see in the lower arch, we're progressing quite well, but notice that my lower right cuspid clinically already is upright, even though on the ClinCheck it should have still had quite a bit of distal root tip. So I do find, because aligners are much softer than a stainless steel wire that we would typically do this on, they do upright more readily, even though you don't see that in your ClinCheck, which is one of the reasons why I try to make my uprighting at the very end rather than initially, because once you sort of upright it and you are only relying on translation, it makes it much more difficult to then keep the root upright and parallelism. So here we're ready for an implant placement. Again, with aligners, it's wonderful. You can place the implant, just remove the align during the time of the surgery, and then you can put it right back on. Very often for these cases, because their pontic sites are changing often, I have my patients just place orthodontic rope wax in the edentulous sites. It saves me from having to stick resin or anything else in there. It looks quite reasonable. It's not the most aesthetic thing in the world, but I've done this hundreds of times and most people don't object to it. It's nice and hygienic. Immediately after the surgery, she can just put in a little bit less orthodontic rope wax to make sure it doesn't impinge on the tissue, and life hasn't changed at all. So at this stage, we're going to order a little bit of refinement just to detail things. So here's a refinement ClinCheck. My refinement ClinChecks are usually geared towards just individual tooth movement. Most of the major movements should have been completed, and the occlusal, inter-arch occlusal issue should have been resolved. So you see here we're just doing a little arch coordination, a little bit more root parallelism at the extraction site, and that lower right lateral incisor, which had a lot of root angulation, and we didn't have an opportunity to upright it all the way initially. Now we end up adding an attachment to it and just completing it. So I don't always try to do everything at once. I have no problems breaking up my ClinChecks and my treatment plans into smaller sections, and that way I can hopefully make each one a little bit simpler. Most of these patients over the years, I have been switching aligners weekly, so it doesn't actually take that long to do. So this is how she shows up on the day of insertion of her refinement aligner. So she woke up in the morning, decided to have breakfast, and during breakfast, her bridge fractured and fell out. So now we end up having a really big problem. How do we deal with this with brackets and wires? It's essentially impossible. We would be making some sort of a flipper, and if we made some sort of a flipper, it would need ball clasps or atom clasps in the molar area to lock it into place. If we do that, then we can't correct the buccal root torque that we needed in the buccal segments to get this to settle in nicely. So we would have to accept some sort of a compromised end result while we're contending with this prosthetic problem. But with aligners, this to me isn't a problem at all. I just simply clean it out, fill it with some composite, and stick it right back into the aligner. And I've done this a number of times, even in situations where we anticipated extracting teeth, but we we would do is have them extract it, cut the crown off away from the root, and just seat the crown back into the aligner. The patient's already used to it. She knows how to wear aligners, and it's very simple to just proceed in the same fashion as she did earlier to wear aligners and continue to have refinement of her malocclusion and dental alignment. The only difference ends up being is now we need to place implants in the anterior maxilla to replace the teeth that were fractured, and they are non-restorable. But again, we don't require any additional prosthetics or any changes to our treatment plan because we can continue to simply adjust the bridge, make sure it's not loaded on the tissue, and continue to wear aligners while we continue to detail her malocclusion. So these are just her refinement aligners, and there's a little bit of detailing in the lower arch. And I did bond a couple of buttons in the posterior right because I just was having a bit of trouble settling in that upper molar. It's quite heavily restored. So this was just for a little bit of elastic wear to make sure that it settles in really nicely. And then this is the final result. She ended up having her restorations done, supported by the implant. You can see she finished with a nice occlusion. The only funny thing is that the problem that she originally presented for, which was to replace the upper left bicuspid, is still not addressed. The implant is buried because of financial constraints, and we had to address the anterior first. So you can see from start to end, I think this would have been quite a complex case to address utilizing brackets and wires. But with Invisalign, it's really, really simple to have this process, especially in light of the fact that aligners can function so well as interim prosthetics. All right, so let's move on and try to look at other things that we can do. So one of the things that I love about ClinCheck is, to me, ClinCheck is really a study model of the initial situation that I'm presented with, the final outcome, but it's dynamic. I can change it intermediately. So it's not like a plaster wax up where all I have is the beginning, the end, and nothing in between. So it's a wonderful diagnostic and treatment planning tool that I think is actually underutilized. So this patient is basically a Monday morning orthodontic emergency consult. And we don't get those very often, and when you do, you know something significant happened. So this fellow shows up at my office first thing Monday morning because on Sunday he was out playing soccer, got an elbow to the face, which evulsed the upper right lateral incisor, fractured the upper left central incisor below the bone line, so it's no longer restorable, and subluxated the upper left lateral incisor. And these patients, they might have not considered orthodontic treatment in the past, but now they essentially don't have an option to ignore the orthodontic problem because in their current state of occlusion, they are really non-restorable. There's nothing that the dentist can do. So as soon as he presented to the dentist just sent them my way and said, what can you do here to make this restorable? Now, when they arrive, obviously they're in distress. So one of the first things we do, and I've done this a number of times now, is we just take an alginate impression of the upper arch, do basically a vacuform Essex retainer, and I just add a little pontic at the area where the tooth is missing, stick some wax in it. It takes us maybe a half hour. During that half hour, we obtain their records and obtain an iTero scan, or back in the day, a PVS impression. And within about half hour, we have all the necessary records that I need for my treatment planning, and we can provide them with an Essex retainer that has a pontic in it, which now means they can wear it. They can feel more comfortable, like they're not missing teeth in the interior of their smile. And I basically tell them this is a training aligner. We're going to straighten out your teeth using something called Invisalign, not braces. And it'll feel very similar to this, except it's going to be able to move your teeth, whereas this one is just holding them in place. Okay? And I think if you look at this case right now, there's a number of issues that we have to contend with, but what are our treatment options? I'm pretty certain that if we gathered 10 orthodontists together and looked at this, we could probably come up with 15 treatment all be viable. So how do you determine which is the appropriate one for your patient, which one do you want to utilize, and how do you communicate that with your patient? And really, when they walk in on this sort of emergency consult, I don't have the time to sit and analyze and figure out every last nuance of this. All I tell them is, you know what, here's your retainer. Why don't we meet in about 2 weeks, and we'll go through a few different treatment options of how we can resolve this for you, and we'll come up with the most appropriate plan. That'll also give me an opportunity to reach out to the general dentist to get their input of what else is going on. So that's what we decide to do. So really my first clin check usually ends up being, you don't have to spend too much time on this. Just submit it and say, please align. There's not much more that you have to do. It just gives you a starting point and gets the process going. It gives you all your tooth size discrepancy, gives you the sizes of the teeth that allows for planning for prosthetics, et cetera, et cetera. So it's a wonderful tool to sort of get started. So here's the initial clin check, and it really is nothing magical. All I did is submit it and say, don't make any AP changes. Just align upper, align lower, and give me Pontics at the 2 missing teeth. So now I know that the one side is a lower class 2, the other side is a lower class 3. Obviously, I had a deep bite to begin with. I have a pretty good idea now how large the Pontics have to be. Can I get implants that are small enough, for example, to accommodate that upper right lateral incisor because they're very small? And it starts the conversation with the general dentist, how are we going to address this? More importantly, it allows me to now send this back to my technician and start working on different treatment plans because, again, there's a lot of ways that we could address this. I'm sure some of you are sitting there and thinking, I would do this or I would do that, because there's so many avenues that we can take here. So I tried for a surgical plan, and here we decided to take out a lower bicuspid, align the lower arch, decompensate the upper one, plan for 2 implants, and then a mandibular advancement because he is a little retrognathic. So I don't think it's the most ideal plan, at least not for me, but it's a viable one, and it allows me to sort of test drive it and see what it looks like. I also tried another plan, with extractions, and here we decided to extract 2 upper bicuspids and 1 lower left bicuspid to see if we can use that space to create larger Pontics at the edentulous site to basically try to get more space to allow us to get implants done that are more restorable because upper right lateral incisor that's 5.5 millimeters wide is pretty challenging to restore. But the decision was kind of made for me because when the patient went back to have the root removed of the upper left central incisor, upon extraction of that root, it was also noted that he had a fracture of the buccal plate, and a big chunk of it came out during the extraction. So now we got into an issue where in order to restore with an implant the upper left central incisor, we would now start getting into bone grafting and all these other issues that come along with lack of supportive osseous structures. So I scratched my head and thought maybe I can do a different plan. So I sort of came up with this one where I decided to do a substitution type case. I extracted the lower bicuspid on the lower left to resolve the crowding, but decided to do a sort of a substitution case up on top where my cuspids became my laterals, and I wanted to utilize the upper left lateral incisor basically to remodel the bone at that site. It was luxated during his injury, so we weren't certain if it's going to survive or not. But this was sort of addressing it, saying, hey, if we can get a little bit of bone remodeling in this area, then maybe we can at least eliminate the need for a bone graft and just stick with a straightforward implant. So that's sort of the plan we decided to pursue. And I confirmed this with the general dentist, can we make this restorable? And everybody thought that that was a reasonable plan, including the patient. which now felt that he didn't really need any more teeth removed except for the lower left one, which was necessary for dealing with the crowding. And in the upper arch, we didn't have to worry about bone grafting, implants, anything else. We simply had a restoration to do on the upper left lateral incisor, knowing that it had guarded prognosis. So here we are utilizing our ClinCheck. And you can see things are coming along nicely. We're getting alignment on the lower arch. My cuspid on the lower left is lagging behind a little bit. I wish I had a bit more of a gable bend in that area, but not too bad overall. The upper arch is coming along nicely. You can see on the upper occlusal photo how big of a bony defect there is on that upper left central incisor. There's essentially no buccal plate. So the lateral incisor is moving through cortical bone, and it's sort of trekking along. Not the best, but enough that it's staying vital, and we're getting nice, healthy tissue now. It's not tracking the best, so we are going to now obtain a mid-course correction to try to help out. We didn't lose the upper left lateral incisor, so we know we can continue with this plan. So just tidying it up a little bit. Same plan, but just adding a little bit more of a virtual gable bend, and I probably should have done even more than that. In the other arch, just add a little bit of class 2 elastics, continue to resolve the deep overbite, which I find you always have to overdo a little bit more in a ClinCheck than clinically. And then I got this new, nice, optimized attachment, which actually tracked really well up until the time when the power ridge ended up auto-populating on my upper central right incisor. So I've learned over the years that, I don't mind optimized attachments at all, but when you have a very small tooth, like a lateral incisor, with a small optimized attachment and a power ridge next to it, it often ends up letting go of the optimized attachment. At least that's been my experience. So if I had to do this all over again, I would have probably just removed the power ridge and maybe even slowed down the movement. I mean, after all, this is not a typical case. This is not an average tooth movement through average bone. So who knows exactly how well it would have worked out otherwise. But we managed to get through it. I needed a little bit of a power arm at the end to upright the root a little bit more because it was lagging behind. But we pretty much managed to get everything else sorted out. We got the lower arch lined up and placed some retainers. We got the upper arch lined up. We got good cusp to fossa relationships in our buccal segments. And we managed to rebuild quite a lot of the alveolus at the upper left central incisor and maintain the vitality of that lateral. I mean, it still has a questionable prognosis long term, but at least now this is becoming a case that is restorable because we can provide an implant or we can do a 4-unit bridge from the cuspids. There's a lot of options available here to us. This is what the final restorations ended up looking like. It's a couple of crowns, and the patient elected not to reshape or do anything with the cuspid. Just flatten the cusp tips a tiny little bit. Considering where he started out when I met him and when he finished off, I think it's a very, very reasonable plan. And again, I utilized here ClinCheck to give me a lot of different options, a lot of different scenarios, and plan for the necessary tooth size that I needed to finish this successfully. So let's continue and dive into divide and conquer. So when it comes to things like divide and conquer, I really look at different components of malocclusion. For any of you that have had a chance to watch my presentation at the last summit, it's called an Ace Up Your Sleeve. I really do divide up my cases into sort of vertical, AP, transverse issues, and don't always necessarily try to resolve everything all at once, and not necessarily by one means possible. Sometimes you need other things incorporated into your overall orthodontic treatment plan to make this work. So I wanted to share with you about Invisalign and its limitations and how you can utilize it for surgical patients. And I think there's been quite a lot of progress in this area over the years. At the summit, we're starting to see more and more presentations of how orthognathic surgery can be done with Invisalign patients. There's been examples of what can be done with utilizing aligners and just buttons on some teeth. There's been examples of utilizing TADs to settle in the occlusion. But the stumbling block ends up being one, the surgeons that are performing the treatment, obviously they have a lot more to lose if something goes astray than we do. So at least in my hometown, I'm still getting a lot of reluctance in trying to do a lot of these cases with just aligners and buttons. But more importantly, the bigger the osteotomies become, the more challenging it really becomes to utilize aligners. And I'm not aware of anybody that has been able to do segmental osteotomies with aligners. So this young lady is actually a sister of a brother that I already treated with orthognathic surgery. There's a very strong genetic component to this family, so we knew she was going to be a surgical case. So we let her fully grow. I did expand her when she was younger because with these class 3 cases, you know they always end up having a transverse issue. And even after all the expansion, as she continued to grow and stay in retainers, we're still a little shy. So we're going to try to work her up for orthognathic surgery, and she's really not dying to have braces like her brother did, probably 7 years earlier. She's heard of Invisalign and really wanted to utilize Invisalign. And I certainly don't want to be restricted to offering Invisalign to any of my patients. I just tell them we might have to utilize other means than just aligners to get some parts of your malocclusion resolved, but hopefully as little as possible. So let's talk about her a little bit. Here's her radiograph. You can see she's quite a substantial class 3. I don't really think I had any other options outside of orthognathic surgery to get that fully resolved. But other than that, her radiographs are unremarkable. We've had the wisdom teeth removed a long time ago, so she's ready for orthognathic surgery at any point in time. We're basically waiting for skeletal maturation. So her clin check is actually fairly straightforward. With aligners, I can certainly align all the teeth. I can certainly obtain my vertical alignment, so leveling of my arches. It's a great treatment planning tool, again, because I can use the elastic jump to measure how big of an AP change this is and communicate that with the oral surgeon so we can start making decisions. Is this going to be a single jaw osteotomy? Is it going to be a 2-jaw osteotomy? So the biggest challenge that we had was really the transverse dimension, because I still needed to do quite a bit of arch development. We were only about shy 2 millimeters in the molars, but 2 millimeters at the molars can be quite challenging at skeletal maturation. But because we wanted to utilize aligners, I offered to do this, and we just said we're going to back it up with cross-arch elastics. So I set myself up to just bond some buttons in the lower buccal segments and on the lingual of the upper bicuspid, and just utilize cross-arch elastics during her aligner wear. So our clin check's not terribly complex or terribly exciting. It was just designed to basically address certain parts of her malocclusion, the alignment, the leveling. The AP change was really a decompensation because we know surgically she's going to have full AP correction. And the only one that was questionable is how do we deal with the transverse, okay? So that's how I'm sort of breaking down this problem. The transverse issue can be either resolved by a SARPI, and we really didn't want to do that. She already had an expander at a younger age, and we weren't that far off. We're only a couple of millimeters shy, so we thought, if we get lucky, maybe we can even get it coordinated with the cross-arch elastics. And if we didn't, for a small amount of transverse discrepancy, we can always look at the possibility of doing the maxillary osteotomy in 2 pieces rather than a single piece. So that's sort of where we're at. That's our unknown, and that's where we're using some auxiliaries with elastics, and we'll reevaluate the case as we line things up. So this is where she is, about 16 months of aligner wear. I do find that I have to slow down the aligner changes in some of these cases where you have to decompensate them because the musculature is just so strong, that especially to procline the lower incisors, the lower lip is always driving the lingual. So it requires a little bit more time. Still not unreasonable for fairly severe class 3. 16 months to coordinate and decompensate, I don't think is an unreasonable amount of time. There was no refinement required, nothing else, just straightforward changing aligners and wearing cross-arch elastics. And when we got to this stage, we basically took some models, tried to fit them together, and noticed that we were still tight transversely. We still needed to address the transverse issue. The aligners didn't give us enough coordination, or the elastics. And the exact same thing would have happened with wires. This is really a skeletal problem, not a dental problem. So I don't fault the aligners here at all. This was just part of our overall treatment plan. So what can we do now? Well, I've been doing orthognathic surgery with aligners for years, even before buttons and elastics, because sometimes when we had to do it, we just ended up lining things up and then tell our patients you're either going to need arch bars to undergo orthognathic surgery or braces. And it's not maybe what the future holds, and hopefully we'll get better with this, but it's not the end of the world if we're getting into very complex osteotomies. So arch bars are not the nicest thing for our patients, and I want my patients to like me. So rather than arch bars, what we did is just do some indirect bonding of some inexpensive brackets. And you can set them up so they're all in line. And I place a stainless steel wire that's coordinated. I've done this many times before. We usually place the wire in the brackets about a month before the planned surgical date. That's because no matter how good I am with bonding my brackets and no matter how good I am with coordinating the wires, there's always a little bit of play. So I want to make sure that when she gets her surgical split made, it'll be absolutely passive. And then I usually see them a day or two before surgery, and we just add all the surgical hooks that crimp on at the time. So basically spends about 4 weeks in brackets and wires pre-surgically to make sure everything is done properly. The treatment plan ended up being a 2-piece maxillary advancement, and because there was some concern for the position of the nerve in the mandible, rather than doing a sagittal split, it was decided that a vertical ramus osteotomy is going to be performed in the mandible, which then basically sealed the fate for us, because at that point in time you have to be in intramaxillary fixation with a splint. So outside of doing plates that are splinted together, I don't think we really had any other option outside of brackets and wires, arch bars, or anything like that. I don't think anybody would be able to do this with just aligners and buttons. It just starts to be way too complex. But this is what she looked like 4 weeks post-surgically. You can see she's in intramaxillary fixation. She's got her splint in place. I always like to check up on them in about 4 weeks after surgery, just to see if anything broke, if anything's off, if we have to anticipate any changes in the following appointment. But she looks great, and she's having nice facial changes. Certainly softened her up, looks a lot more feminine. And no other issues, really. So another 4 weeks until she comes back. This is where she is at 8 weeks post-surgically. And at this point, we scheduled her to basically remove her brackets and order some detailing aligners to just settle in her buccal segments and do a little bit of finessing of any teeth that aren't perfectly straight. In the future, now that we have scanning technology, I think if you really need to scan their teeth pre-surgically, but don't scan their bite registration and utilize that immediately after surgery to order your aligners. That way there's no lag time. But under this situation, I knew if I was to order some aligners for her, it would take approximately 4 weeks for them to come in, and then she would probably need maybe 2 months of aligners just to settle this last little bit in. And I always give my patients the option. I'm happy to order more aligners for you, but you probably know that this stage, most patients just want to be done. They don't really want to forego any treatment options that would allow them to be done sooner. So the other option always ends up being is I can put in a little detailing wire for you, wear some rubber bands, and we can take everything off in about a month and you're done. And that's what she elected. And this is what she's like about 4 weeks later. So this is a total of 12 weeks post-surgically. We'll replace her permanent retainers and remove all the brackets, clean her up. I think it worked out really nicely. You can see her pre-surgical state, her decompensation state, and then her final occlusion. Her total time in brackets and wires, which I consider to be an auxiliary to aligners, was a total of 4 months. So 20 months for orthognathic surgery, two-piece maxilla, and mandibular reduction, I don't think is an unreasonable amount of time. And certainly 4 months in braces is not an unreasonable amount of time. But I do hope that in the future we will have even better modalities that will allow us to bypass braces entirely. But until my surgical colleagues feel perfectly safe and confident in doing that, this is how I can proceed to do very complex osteotomies without necessarily declining aligner therapy to my patients. This is where she started out. You can see she was quite masculine looking and quite a bit softer after the orthognathic surgery. Nice end result. Very, very happy with it. So that's how we divide and conquer. Just look at different parts of your malocclusion, and some of them might be resolvable by aligners, but some of them may not be. And if they're not be, then what auxiliaries do you need in order to make it work? So let's take a look at another case here, which is going to give us a similar sort of issue and how we resolved it. So this young lady comes in to see me, and she's quite retrognathic, has a class 2 malocclusion. And really, under normal circumstances, I would have no qualms treating her purely with aligners. It's a little bit of derotation of the upper molars, some class 2 elastics, hopefully some favorable growth, and everything should hopefully work out wonderfully. Nowadays, in Canada, we have the mandibular advancement functional appliance feature that's available in aligners. And maybe she would be a great candidate for that as well. So we get hopefully some growth modification and mandibular advancement here as well at the same time. But the complicating factor that I encountered here had to do not so much with her malocclusion, the class 2 skeletal tendency, but the fact that I had an ankylosed lower left first permanent molar. So the problem became is, how do I run class 2 elastics here? We really wanted to remove the ankylosed tooth. The sooner the better, because you can see it's already creating quite a large osseous defect, and we didn't want them to keep progressing any further. We ended up obtaining some 3D imaging to really assess it and see what's going on. But the decision was the sooner we can remove it, the better, to allow this bone to heal up, and with her growth, hopefully get some of resolution here without having to deal long-term with a vertical bony defect. So the challenge I had is, if I'm trying to run class 2 elastics off the second bicuspid, well, that's a really short vector, so it's not really going to work great for me. Alternatively, if I try to run class 2 elastics of the lower left second molar, it's already severely tipped to the mesial. It's just going to tip way more, so I'm going to make my life much more difficult long term. So what I decided to do is break up my problem into what can be done with aligners and what can't, or at least what is less favorable at this point in time. So I decided to utilize a functional appliance to give me some expansion in the maxilla, so deal with my transverse issue, and AP correction. So I utilize sort of a Herbst crossbow type appliance. Whichever one is your favorite would have worked just fine. But it allowed me to sort of take care of the problem that I had, which is transverse AP, and get a nice Class 1 platform. So you can see her. She still has malalignment of her dentition. She's certainly getting a little bit of a better profile. I now have Class 1 cuspids bilaterally. So now this is becoming a much simpler, it's no longer a complex case. And I can tackle this with aligners very easily now because it's just a lot of alignment and sort of settling. But the one problem that I still have is my lower left second molar has gotten even worse. Now it's more severely tipped, and I really want to utilize aligners at this point in time to upright it, which becomes a huge challenge. Again, I don't want that to stop me from utilizing aligner therapy. I just ask myself, what else is it that I need to do in order to make this work? So here's her ClinCheck, and her ClinCheck is fairly unremarkable in most parts because, like I said, it's just a little bit of arch development and then straightening, so nothing to get excited about. But in the lower arch, what I chose to do is set myself up for a little auxiliary to upright that molar, and I will show it to you what it looks like and how it works. And the concept behind that is really, in order to move teeth, we need a vector. So a vector really consists of a force and a direction, and most of the time our aligners do both. They provide direction of tooth movement, and they exert a force on a tooth to get it to move. But it doesn't mean that we always have to do that. So here I have some optimized cutouts so that I will use a little segmental wire here to upright this tooth. And it's really a best of both worlds, because if I tried doing this with just brackets and wires, what happens is the molar ends up extruding, becomes stuck in traumatic occlusion, and it typically tips towards the lingual because the cortical plate on the buccal of the mandible is so much harder than on the lingual. So it's a very difficult movement to do with brackets and wires because it's extremely difficult to control direction. It's simple to exert the force because certainly wires can do that, but direction ends up being the challenge. Similarly here, with aligners, the challenge becomes in exerting the force because we don't have much tooth mass to catch onto. We could have tried maybe twin attachments, maybe placing them both on the buccal and the lingual, but no matter what, it's just a difficult thing to express with aligners right now. But aligners are fantastic at providing direction. So I have brackets and wires which do a great job of providing force but poor at direction. And then I have aligners which in this case are fantastic at providing direction but struggle with force. Can we combine them both to get best of both worlds? So I've done this a number of times now because I do end up seeing so many pre-prosthetic patients and I utilize aligners, and it's a very common problem to deal with lower molars that have tipped mesial over the years of being unsupported next to edentulous sites. So it's a little uprighting spring. It's very simple to make. You can look up in your Profit textbook. It's in the last chapter. And basically what it is a little bit of a supporting arch wire on my bicuspids, which provides the anchorage, and then a TMA spring, which is designed to upright the molar. The aligner is locked in onto the bicuspids with a couple of attachments. So now what I'm getting is with brackets and wires, that lower molar would be moving lingual and extruding. Well, the aligner is preventing it from doing that and actually only allows it a certain direction. You can see that aligner doesn't fit perfect right now. That's okay. The only path that molar can go in is into the aligner. Eventually, it'll find its way and get itself seated. Similarly, with brackets and wires, the biggest challenge is that you get all the side effects of uprighting that molar exerted on the bicuspid. So they often intrude and tip and get blown out buccally. Well, now my aligner is sort of anchoring them and not allowing them to move anywhere. There is fancy omega loops and compensating loops you can make in your arch wire to try to minimize that, but this is just so much simpler and there's nothing really to worry about. Just let the two systems work in tandem. And this is where she finished up. You can see she got great alignment using her aligners. She got favorable profile changes with her functional appliance, nice buccal segments. And what you want to see is probably the radiograph of what the molar looks like. And you can see initial presentation, post-functional appliance, and post-aligners. And we started out with a very tipped molar. We uprighted it with the little uprighting spring. And then here's the final one, just adding a permanent retainer in that site until she gets to be old enough where she can get an implant. And fortunately, most of that vertical bony defect that she had at the ankylosis site has resolved. So she's a very good candidate at this point in time to obtain a implant long term. So it's a nice way of addressing these issues. And again, I didn't have to be forced to do everything with aligners. Sometimes the tandem of the two systems works just so much nicer in harmony. So the last thing I want to talk to you about is looking at being selective with your anchorage. And what I mean by that, as we will discuss, is I don't always try to do everything in my first set of aligners because it becomes way too cumbersome and it's almost impossible to predict exactly what's going to happen for some of these patients. So I was told at one point in my career that aligners cannot correct crossbites, and that was one of the limitations that they had. So here's a young fellow which actually only has one tooth in proper occlusion, and that's the upper left central incisor, and only half of it is actually in proper occlusion. Every single other tooth in the entire arch is in a crossbite. So I looked at this and asked myself, can I do this with aligners? And I'll admit to you, it's not the first one that I treated, so I'm pretty confident I now can, especially when it's for dental compensation, obviously not for skeletal issues. But I have no qualms setting this up to deal with the smell occlusion with aligners, but I'm not going to pay attention and scrutinize the movement of the upper left lateral incisor and whether my ClinCheck is absolutely perfectly designed for that. I mean, I'd be lucky to get him into some sort of a stable occlusion in the first 6 months or 8 months. What I want to do is just deal with the big issues first. So what I want to do is see if I can get some expansion in the upper arch, see if I can coordinate the arches, see if I can get him into stable occlusion. Everything else doesn't really matter. So this is how we're going to set it up and try to deal with all these other issues. I have over-erupted molars in the first quadrant, and we'll try to address that. But again, not everything all at once. We have a tipped molar in the third quadrant. Again, I want to deal with that, but not all at once. Right now, let's just pick the issues that are big here, deal with those first, and set up our anchorage to do that. So this is what I mean by it. This is the way the ClinCheck is designed. So most of it is just unraveling, but I do want to give myself an opportunity to utilize cross-arch elastics. I think that's fairly obvious. So you see I have some cutouts. But what I want you to notice is that my posterior is pretty stable. I'm not doing any expansion in my molars. I'm basically utilizing my molars as anchorage to develop the rest of the arch. Because I don't want to strain the entire aligner, sort of like trying to put in an arch wire that's just massive. What I want to do is utilize that as anchors, and then I've provided myself with some optimized splits here in my aligners so that I can use cross-arch elastics. Anytime I can utilize features built into the aligners, I prefer that. Overdoing it with buttons and elastics is just less stuff to break. And in the second quadrant, notice that I'm intruding the bicuspid here, but I'm utilizing the cuspid and the molar to give me the anchorage to do that. I can't intrude all the teeth at once. I can only selectively do it. Same thing on the right quadrant. I'm utilizing the cuspid and the last molar, the terminal molar, to intrude the first molar and the two bicuspids to try to level the arch. But if I tried intruding all 5 of those teeth, nothing would happen. I need anchorage somewhere. I need something stable to get other teeth moving, because orthodontics is all about equal and opposite reaction. You know, some teeth move against other teeth. So anytime I see ClinChecks when all the teeth move in a unison direction, it's just not going to work. And I have almost a year worth of aligners, which are going to be switched weekly. And again, I don't think that that is unreasonable amount of time to get this arch development. So I'll show you the progress here. This is how I utilized cross-arch elastics. I did want to have buttons in the upper arch, but I just had some hooks on the lower one, and that's how they engage. You just need attachments on the bicuspids to make sure that your aligner doesn't slip off the teeth. And a lot of this is just arch development, but notice that my upper molars are staying put. They're not changing transversely. It's just in the anterior. Okay. More development. I had a little bit of problems tracking of the upper right cuspid and the upper left lateral incisor. Again, at this point, I really don't care. I just need to get to a better position. And finally, at the end of all the aligners, this is where I arrive. And this is not too bad. This is now starting to look like something I can deal with. Yes, I need some tooth detailing. And yes, now I can look at expanding the posterior of the maxilla, but I got a much more stable frame to work on. So my refinement ClinCheck sort of consists of this. A lot of tooth detailing, which is okay, get my cuspid back down into position, and now I change my anchorage. So my anchorage is on the bicuspids in the first quadrant to intrude the first and the second molar, continue to level my occlusal plane. And on the left, I already set myself up for an uprighting spring like I just showed you. And nowadays, if you ever need to utilize this with a Pontic, a lot of the times it's nice not to have a Pontic, but if you ever need one, just make sure that your Pontic buccal lingually is narrower, so that way you have space for the arch wire to sort of fit in there. And in the upper arch, I'm now developing the posterior of the maxilla and utilizing the anterior as my anchorage to continue to develop this and resolve the entire crossbite. So this is sort of my second aspect. What can I do now? You know, how do I get closer to where I need to be? And that's it. So you can see I'm just utilizing aligners. Everything's tracking nicely. I place an uprighting spring so I can get the mesial root tip on that lower left molar. And we're progressing. Everything's coming along nicely. Tooth is uprighting. My cuspid, again, didn't behave very nicely, and it's not tracking terribly well, but it's getting better. We're certainly getting intrusion in the first quadrant, so my occlusal arches are leveling, and you can see all the arch development in the maxillary arch. Now it's starting to look really, really nice. So this is the radiograph to show you that you can upright those molars, and this is very consistent. You'll see this over and over and over again. And this is where I got to at the end of my aligner. So I got good alignment on top, good alignment on the bottom. I'm still not happy with the rotation on my upper right cuspid, but everything else looks pretty great. So now the question becomes, can we even do better? And that's where we get into things like TAD. So I am very new to TADs, and I certainly don't have tons of experience with it, but I break down TADs into sort of 3 categories. So this is a case of Dr. Drew Ferris, a colleague and a friend, who sort of showed me, hey, you can use TADs totally independently of aligners. So here's an impacted cuspid where the ballista spring is purely utilized for the extrusion of the impacted cuspid while the aligners are doing everything else. You can also use TADs directly where you're hanging elastics off the aligners and across aligners, or off the TADs and across the aligners, to help things with like closing anterior open bites, where the TADs are used to directly applying force via elastics. What I'm dabbling with and trying is to use TADs indirectly in conjoining with aligners because, again, I have a lot of pre-prosthetic patients, so I'm trying to limit and cut down on the number of these segmental arch wires I've had. And this is my sort of first crack at it. So I ordered yet another ClinCheck because now we wanted to see what we can do with the edentulous site in the second quadrant, because it's not big enough for a full tooth. It's too small to, we don't really want to place a full-size one. So we wanted to see, can we design a ClinCheck to basically protract the teeth and close the space? But you will notice that the cuspid and the bicuspid aren't moving at all. So I have sort of absolute anchorage here. And this is just utilizing a TAD, as I will show you in a second, that is splinted to the second bicuspid, or sorry, the first bicuspid. So the TAD provides the anchor, it's laced to the bicuspid, and then the aligner is locked in hopes of getting this uprighted. This is sort of what it looks like. And again, I'm not terribly experienced with TADs, but that's my early stabs at it. Everything else in the aligner will hopefully do. Now, again, the bone here is not favorable. You have a big bony defect. Perhaps we could utilize twin attachments here, or maybe even Propel to help us upright it. I'm about halfway through this, so I don't have the final slides, but I can show you this is sort of the progress. If you look at the maxillary photo, it pretty much closed the space. The root is still lagging behind, and my aligner is bending a lot. So I get the feeling I am going to have to do some sort of a segmental mechanic here, but certainly this is a work in progress, and it looks like it has a pretty good future ahead of it. So to me, a lot of people talk about golf analogies, but I'll tell you, to me, these complex cases end up being a little bit like parallel parking your car. And the reason why I say that is all of us know how to parallel park our cars, and it looks something like this. We first ride up and do one part of it, then we painstakingly try to do another part of it. And it's not very sexy, and it's not very exciting, but if you do it systematically, bit by bit by bit, you know you can get to your final destination where you need to be. You just have to take the appropriate steps. And if you do that systematically, you will be successful. And it's the same thing in these complex cases. Break them down to something that's simpler and utilize the different steps to get you to the final goal. I think that's a very reasonable way of approaching it. Now, I hope long-term I'll be able to parallel my car a little bit better, and I'll show you how, but I'm not there yet. Hopefully this is the future. Which would be a ton of fun, but I don't think I'm quite ready to do that with all my ClinChecks and all my complex cases just yet. So I want to leave you with these sort of 5 components of how to look at your complex cases. I want you to concentrate on the fact that complex cases are just interconnected through a lot of simpler parts, and if you just keep focusing on the simpler parts and utilizing your knowledge to deal with systematically one at a time, you can be very successful at using aligners for some of these more challenging orthodontic cases. I want to thank you for spending this Friday of a long weekend with me. Our slogan at my practice now is we are passionate about your smile, but certainly when I do these presentations and share some of these insights with you, I also want you to know that I'm very passionate about Invisalign. If you need to reach me for specific questions about this presentation, you can do so directly. If you don't get an opportunity during this presentation, here's my office email address. Or you can also reach me through the Ortho Coach services. We're going to come to a conclusion now. This is basically the information that you need in order to retrieve your continuing education certification. And I will now sign off.
Thank you, Dr. Iwasiuk. A couple of quick reminders. Please go to the link that's on your screen right now to take your survey and get your CE certificate. 1 week from today, this entire program will be archived at the Education tab on your Invisalign Doctor site. I want to thank Dr. Iwasiuk again for a great presentation and for all of you taking time out on your Friday to join us. We look forward to seeing you on another Ask the Expert webinar. Thanks very much.